infectious disease pharmacist at UI Health, University of Illinois, Chicago College of Pharmacy. And I am honored to introduce your next speaker, Dr. Erin Weslander. Dr. Weslander is an antimicrobial stewardship program coordinator at Northwestern Medicine System. After training at the University of Minnesota and a 3.5-year COVID-ridden ID pharmacist position, running a stewardship program at UPMC Children's Hospital of Pittsburgh, she joined the Northwestern team in Chicago in 2022. She has been a dedicated steward in the form of being a vegetarian for the last 20 years. She is passionate about stewardship outcomes, quality improvement, gram-negative infection treatment, and dogs. So please welcome Dr. Erin Weslander.
Thank you for the introduction. I wrote that one last year for speaking and then forgot that I wrote all that, so that was funny. All right, so today we're going to talk about sort of advanced inpatient implementation and outcomes. So I'll start with objectives. So we're going to go through some overarching concepts of implementation science and then kind of versus quality improvement, and then apply principles of both to stewardship initiatives. And then we're going to discuss some practical outcomes tracking for stewardship interventions. So just to get a feel for the crowd, who works in acute care, like in the hospital? Okay, great. Okay, just double checking. That makes it a lot easier just for these next questions. Okay, so raise your hand. How many of you have implemented an antimicrobial stewardship initiative? Yeah, awesome. Okay, and then how many of you had studied and presented on your initiative? Most people. Okay, great. And then have you planned ahead and used checklists and applied implementation tactics to your initiative? A couple. Great. Okay. This will be like moderately helpful then. Very good. This was Google. So I had to transition. It was too big of a PowerPoint to send an email, so it went to Google. So I apologize if any of these things happen. Okay, so the pitch. We all wanted stable and decreased antibiotic resistance. We all want best patient outcomes. And so these 2016 IDSA guidelines were based on pretty sad data. I have a summary, and I think it's like 6 is moderate quality evidence studies included. There's 17 of their recommendations are based on low quality evidence, and then 4 have like no evidence, they're just recommendations. So not very good data that we're kind of doing all of our initiatives based on. So why are we putting in all this effort if we don't know what works best? And so we're going to go through some things that we can use to make our internal data better and potentially external data better, which is what the green thing says. Okay, so implementation science. Have you guys heard of implementation science? Okay, get some head nods. Very good. So quickly, kind of the difference between quality improvement and implementation science. So a lot of this is all from this Lavorsi et al. Paper, 2022. So I have sort of 2 main references that I have linked on a slide by itself because they have really great checklists and really useful studies. So I'll refer you to those for more details. But kind of the difference, quality improvement, it's context dependent. It's a fixed specific local problem. The approach and evaluation are similar. So you're going to design and test strategies to address your problem. You can do qualitative or quantitative outcomes, process, and barriers or facilitators to change. But the models and frameworks are a little bit different that they have in these 2 areas. So Six Sigma is probably the biggest one, and we'll go over that second. First, we're going to talk about implementation science, which is broader. It's meant to be generalized to other sites or your next initiative. You can use the same framework. And so there's some different models for that one too. The pop-ups didn't work. That's okay. So in summary, quality improvement is what I'm doing here now useful to me? And then implementation science is, does the process work well? And then can we apply it to other things? So have any of you done implementation science before? One person, two people. Okay. Sounds good. So we'll go through kind of the basics of it and then apply it to stewardship. Okay. University of Washington has a really great website with a bunch of implementation science information. So they have the definition as how to get what works to the people who need it with greater speed, efficiency, quality, and relevance. And then another definition, this one's from Northwestern. Implementation science is the study of systematic methods to promote uptake of evidence-based practice into routine practice. So similar to quality improvement, the ultimate goal is improving the quality and effectiveness of our health services. So these are the two articles I'm going to reference basically the whole time. So the first one is leveraging implementation science to advance antibiotic stewardship practice and research, and that's the Lavorsi 2022. And then Langford et al. In 2024 published 5 steps to high quality antimicrobial stewardship research. And I'm going to dig into this one because he has a really great checklist that we'll go through. Okay, 2 things I would definitely refer you to. So implementation strategies, there's 9 sort of buckets of implementation strategies. And so I'll go through these kind of quickly. I have some examples for each one. So the first 4, we've got providing interactive assistance. So if your intervention is facilitation or local assistance, developing stakeholder relationships. So identifying champions, early adopters, organizing team meetings, that can be an intervention. Supporting clinicians so you can revise their role, you can provide data, that could be an intervention. Financial strategies, pay them, that's a great one if you have the money, or funding innovation as well is a strategy for implementing change. Okay, and then the next 5, we've got use, evaluation, and iterative strategies. So this one, audit and feedback, obviously we all do that. And then re-examining and re-implementation. So reiterative, going back and forth. Adapting and tailoring to the context. So maybe you roll out an initiative and then you tailor it to the sites, and that's your angle for your initiative. Train and educate stakeholders. That one's pretty easy. So train the trainer type situations or making education. Engaging consumers by increasing demand, mass media, or involving patients and families. So getting it from the other side. Maybe your intervention is targeted at patients. And then the last one is change infrastructure, which of course is one we all know quite a lot about, which is mandating change, which is hard, but you can change the medical record or the physical equipment. So those are generally the buckets for strategies for implementing things. Okay, this next one is a checklist of checklists. And this one, so this is the Langford et al. Paper, and I would recommend reading through this before you do an initiative and trying to pick out a few things that you might want to use. So it's essentially like, here's a checklist of things you could use, and you kind of pick one from each. So A is plan ahead using implementation science. So the purpose of it is to make sure you don't miss any important steps. So I am sure we've all rolled out initiatives and then, oh shoot, we forgot that when we changed that, order in the EMR, it affects the children, and we forgot about kids. Dang it. So trying to think ahead for just things like that. So having a checklist ahead of time, knowing what people you need to talk to before you accidentally change something and you've implemented it. So that's the first one, is planning ahead. There's the tidy checklist. So that's to ensure the actual intervention rollout is well planned. So we're going to go through each of these more in depth as well. C is use a checklist for your study components. So that's another one. If you start collecting your data, if you have to submit through IRB, you're going to think about it ahead of time. But if you're not, if you're just doing quality improvement, having a checklist of things you should always collect is really helpful, so that you don't have to go back into the charts. Everyone hates that. D is select a study design. So that's really when you're ahead of time preparing to publish. So ensure your design matches the type of intervention that you're doing. And then the last one is measure effectiveness in meaningful outcomes. And of course, we're going to talk about more outcomes later today too. But making sure that what you're reporting is actually useful. Okay, so this is a plan ahead. So this process is the Iowa model. So this is just one of the options you can use as a checklist. So this kind of walks you through, this is just the first half. And so I just applied it to an initiative that we did this year, which was improving UTI prescribing. We did not plan ahead with implementation science, but if we would have, might have been how we did that. So first you identify what the issue is, you state the purpose. Is it a priority? That's a big question. And then if it's not, maybe choose something else to do. But if it is, then you form a team and then you look through the literature. If it all looks good, there's sufficient evidence, then you move on to the next page. So today we're gonna tackle UTI treatment. Our C. diff rates are going up, and we know that quinolones and ceftriaxone have a higher risk than something like cefazolin, but we know that our cefazolin and ceftriaxone rates are really similar for E. coli, Proteus, Klebsiella at our health system. So this was sort of where we decided to make our intervention to increase the narrow spectrum use and decrease ceftriaxone. So we gathered team, urology, hospital medicine, infectious diseases, stewardship, emergency department, looked through literature, got consensus on our change, and said, yep, there's enough evidence, we can move forward. Okay, so priority list. Here's one. Do you guys have a priority list for your stewardship program? No, nobody. Oh, a couple people. Okay. So when I started at Pittsburgh, there was not a stewardship program really in place. There wasn't a stewardship pharmacist before me, so I was sort of starting a new thing. And I walk in the door, and everyone's like, "We need these 75 things." And so, of course, I was like, I don't know where to start, except clearly like make sure we're doing the core elements. Like do the basic minimum. But then what? And so I think the priority list was really helpful. So if you're deciding between several projects, figuring out what's important to you. So a blanket importance category I made for myself. This is all kind of arbitrary to help you organize yourself, but other things you might find important. Is it really quick to get done? Maybe that's important. Is it the direct care and cost savings? If cost savings is really, you're being pressured, maybe that's worth more points. Does it apply to the health system? Then maybe that's higher priority. And so that's sort of a ranking system example. Make your own, but that can help you if you are bombarded with a lot of different requests and what to potentially start with first. Okay, so we've determined this is a priority. So now we're going to move on to the second part, which is actually doing the implementation. So collecting baseline data is important, and then developing your implementation plan, your materials that you're going to create, and then is this appropriate after you've gone through all of your planning? Yes, it looks good, and then you'll integrate it into sustained practice change, and then disseminate results back, which is kind of the end of the Iowa model. So for our UTI example, we'll collect some baseline data, develop a process. So what we did was we had pharmacists intervene on non-guideline directed treatment unless they had previous cultures where they should use something different. And then we started education rollout, obviously to pharmacy, but then also to all the clinicians, all the prescribers. And then reviewing several months post-intervention and continuously feeding back data to the frontline prescribers and to the pharmacists was really, really useful in showing how awesome they were doing and then sustaining change over time. Okay, be clear and tidy with your intervention. So there's the tidier checklist. So this is like implementing rollout checklist. This is really helpful, again, to not miss any steps of what you're implementing. So just, like the name and the why are all things to start with, but the materials, what you're going to need, what things you're going to need to change. So like I said, do you have to change Epic? What does that affect? Who do you need buy-in for? Do you have a micro lab that also does stuff for the outpatient setting? Is it going to affect all of outpatient? And then you have to get a hold of the clinic prescribers, just making sure ahead of time, you know, all of the effects that are going to happen from your intervention. That's where this checklist is really helpful. Where are you going to do the intervention? How long are you going to do the pre and post? Is that enough time to capture data? Do the months matter? Is it like you're doing it during flu season and you're comparing it to post-flu season? Things are going to change. So things like that are really useful to just plan ahead with a checklist like this. And then number 11 and 12 are really important. So planned, how are you going to assess adherence? And then 12 is, was it delivered as planned? Those two, I think we forget to go back and check that it happened as we expected. But that's something that's really useful for the next time you do education in the next round. Okay, C, use checklists to report study components. So this is an example on the right side. If you guys have done quality improvement or IRB, it shouldn't be that groundbreaking, but obviously planning ahead, especially if it's QI where you're not submitting an IRB, make sure you have your study components ready ahead of time, like I said, so you don't miss anything while you're in the charts or while you're putting in the request for data, for example. Then you don't have to go back. Okay, select a study design. So you guys have probably done this as well if you've done any sort of stewardship intervention where you've presented on it. So probably the most common ones here, especially for stewardship, are quasi-experimental, and then oftentimes it's interrupted time series analysis or pre versus post. So that should be pretty familiar to most people. And then E, selecting meaningful outcomes. So we'll talk about this in the outcome section, but making sure you know ahead of time what things are important and what things you might want to capture, such as larger outcomes like length of stay or resistance over time or C. diff. Thinking about that ahead of time is really useful. So there's a couple recommendations on the checklist, like exactly what outcomes you're going to follow. So meaningful outcomes for the UTI, we determined percent guideline directed antibiotic use. Over time, we'll track C. diff, and then length of stay, readmission, larger concepts like that are important outcomes to look at. And then resistance over time, theoretically, will be a great thing to check. Okay, quality improvement. So as a reminder, compared to implementation science, this is really for the local sites. It's still really useful to have internal data and or publish on quality improvement projects, but it is a little bit more specific to your site and perhaps not as applicable to other centers. So we're going to talk through Six Sigma. Have you guys heard of DMAIC or DMADV? DMADV? Have you guys heard of? Okay, plenty of people. Great. So we're going to go through DMAIC. We fortunately have the opportunity at NM to do DMAIC with process improvement team. So we'll walk you through one of the things that we did. And so it stands for define, measure, analyze, improve, and control. So the first few, the left side, the blue bucket is analyze. So define, measure, and analyze go in there. So you put in a bunch of possible reasons things are happening. You pull out the irrelevant information. You figure out a few key drivers. And then you put it into the solution bucket. So then you go through possible solutions for the main drivers of your issue, and then you come out with a few key improvements at the end. You make an intervention pilot, you see if it's working, potentially expand it, and then control for what you've done. So again, this is this slide came from Stephanie from our process improvement team, who helped us through our DMAIC. So the D is define. So there's a few tasks here that you can check off as you're in this category. make a project charter, get the voice of your stakeholders, get them involved early so that they feel like they're involved, and then you can use them while you're implementing your intervention. A high-level process map is recommended, project management tools if they're available, and then potentially financial benefit analysis if that's available to you. So things you can do now, figure out if your institution has project management tools or resources. So all 3 centers that I've been at have had a group, mainly through quality. So probably if you haven't found it yet, there's a group who has some tools that you can use. They may have calculators and Excel for different things that you might need. So that's something you can do now. Okay, so this is our project was, we had the BioFire rapid blood culture panel, and we had a pretty slow turnaround because it was passive. It just went into the chart and people weren't really notified. We did have Monday through Friday. The stewardship team looked at the results and intervened, but we had some pretty big gaps in like overnight, evening coverage. And so we knew that there was this gap, and we knew that we could do better for getting patients on optimized antibiotics early. So that was our problem. We had delays. We had the result, and it would take a while for the intervention to happen. So our goal was to reduce the time from the blood culture positive to under 4 hours. And then we were going to pilot this at our academic medical center and then one of our community hospitals, CDH, to try it at 2 sites. So deliverables, we plan to implement change to reduce the turnaround time and then figure out if we could optimize it system-wide. So there's obviously some different barriers for each hospital. Some of them don't have a machine, so there's different types of delays. So how would we implement it across the system? But first we were going to try it in our 2 hospitals that had it within the hospital. Okay, measure baseline data. So next, we're going to make a data collection plan. We're going to get our baseline data. We're going to update the process map and update the charter based on anything we find during our data collection. And then, so things you can do now. Track down baseline antibiotic use and data options, especially for financial data. So again, there might be a group that can help you with finance data. And so figuring out who that group is and if they can tell you anything about your antibiotic data or your patients with infections data. There might be a group already working on that. So figuring out who those stakeholders are and trying to get involved with them could be really helpful for your initiative that you would launch next. Okay, so here's the process. Should be pretty familiar if most of you have probably a rapid blood PCR, but if you don't, the blood culture is drawn. Once the gram stain goes positive, then it's put onto the PCR machine, and then 1 to 2 hours later, the result comes back, and then it just flows into the chart so people wouldn't get called about it, and then whenever someone sees it or decides to act on it, then optimal therapy would be started. And then there potentially could be a delay in administration. So through that whole process was kind of how we were thinking about what's the delay in people being on being given their optimal antibiotic. So we wanted to narrow the scope a little bit. It's obviously was a lot of patients for both our pre-data and our post-data. The academic medical center is over 1,000 beds, and the CDH, the community hospitals, 450, 500. So a lot of patients. So we were trying to do bang for a buck here. How are we going to decrease potentially outcomes like length of stay? So you can see in this graph on the right side, there's patients who had a positive blood culture greater than 96 hours after admission. So there's a lot of people who are like solid organ transplant, like transplanted during that admission. We're not going to change that length of stay. We're not going to change mortality probably. So we really wanted to focus on the people who were there for their infection. So we did limit the scope to 72 hours after admission for the BioFire, which was also, you can see, the bulk of our patients. So we hit most of our patients, but kind of excluded the probable outliers. We did intervene on them, but that's not who we studied. We didn't ignore, you know, the CTXM gene who was on ceftriaxone. Okay, so here's our timeline, our process map. So this is really helpful if you're trying, like a sepsis initiative, you're trying to get antibiotics, breaking down each of the little steps where things could go wrong. So that's what we did here. Where could our delays happen and what's our baseline data? So you can see the time to biofire order, which is when the gram stain goes positive. That took 22 hours, and then it took 24 hours for the biofire to come out, result after the blood culture was drawn, which makes perfect sense because, the gram stain goes positive at 24 hours. So that was made a lot of sense. But then where's our delay? So our time to optimal therapy was 15 hours in our pre-cohort. And the time to administration after the optimal therapy was ordered was less than an hour. So really, we felt like the 15 hours was the red flag here. So that's why we decided to go for the intervention. Okay, analyze is DMAIC, the A. So what's the root cause of your problem? Look through the data. If we hadn't done a deep dive into all of those timestamps, we don't know what the delay is for sure. It could have been, the nurse administration if they're short-staffed. Perhaps there was a 3-hour delay in getting the antibiotic actually given to the patient, but there really wasn't. So that was not what we targeted. Process analysis, and then determine and prioritize your root causes. So things you can do now, there are some standard framework for root cause analysis, which is the 5 whys. So you keep going until you figure out what is the root cause, which is what we did in our breakout session. So here's an example. So obviously we had somebody walking us through all of this, which was really helpful. But this is all in the DMAIC framework if you look up Six Sigma and DMAIC, so you can do this within your own group. But this is what we did. So we broke it down. There's potential people issues, there's task issues, there's material equipment issues, organization issues, and environment issues. So we split into groups and we were brainstorming. So people, our staff coverage, we weren't 24/7 reviewing these. Our nursing staff to administer the drug could have been a problem. The primary team takes, it's cultural. You round in the morning, you make a decision at 10 when you're at the bedside, and then you do not make another decision until 10 a.m. the next day. And so that was a big cultural barrier that we encountered. Especially at our our community hospital, because they don't have as much coverage for residents covering overnight and things like that. So that was definitely an issue there. Allergies, does it take a long time to get the right drug to the patient because of allergy issues? And then paging the right person, tracking down the right team, that's a people issue. Environment, is there administration delays? Methods and tasks. So the pages and frequency of checking, there was sometimes delayed response. The primary team was not notified real time. Was there a way that we could get to the primary team faster? Consistency and documentation was also difficult to figure out why they maybe weren't picking, we didn't know why there was a delay because they weren't telling us what they were thinking. Materials, so lack of EMR capability was a big issue. To get the actual result paged out. When a blood culture goes positive, the micro lab is paging, the nurse or the person who ordered it. And that's a manual thing. It's not an automatic thing. So we really struggled with how to implement that. And then understanding biofire education, that was obviously a gap. And then organization. So our commitments for stewardship, we're also, we have learners, we're pulled in a lot of different directions. So is there any way we can make that better and make our team faster? Okay, so a bunch of issues were identified. So now we're going to go through improve, which is where you generate potential solutions to all of these big issues that you found. You prioritize your solutions, you prepare, implement, you pilot the solution, and then you can implement it wider. So things you can do now, figure out what your system's priorities or your hospital priorities are, and then making a standard framework for prioritizing projects are the 2 things I'd recommend to be able to be ready to implement solutions when the time comes. Okay, so next we found some root causes. And so we did some brainstorming and we bucketed into short-term solutions and long-term solutions. So what are things we can do relatively quickly, or what are things we should maybe do but aren't going to happen for a while? So maybe we can start working on putting in tickets or requesting framework or doing education for the longer term effect. So those are the two buckets we put things in. So the root causes, we had the stewardship staffing was an issue, weekend coverage was a big issue, and then making sure a lab was ready was also a big issue if we were going to be calling them and or if there was delays there, which there really weren't delays, but at our other sites there were, and so we had to be ready for that. Okay. So some potential things we talked about doing, we really narrowed in pretty quickly on getting our frontline pharmacists trained up to be able to take these. They're already there 24/7. They're already reviewing their patients. So that sort of rose to the top. Okay. How do we get our guidelines better? We had this beautiful, Christy here made this beautiful biofire guideline. It was very explicit. I'm sure you all have a similar one, but it seemed like people didn't, the comfort level wasn't there with, if the gene was negative, you can really, go to ceftriaxone based on our antibiogram. You can do it. But the comfort level wasn't there. And the knowledge of having the document wasn't there either. So how can we get our message across faster? How can we advertise our guidance better? That was something we felt we needed to do. And then how can we get the order change to happen faster? So a few delays that we figured out. Waiting for ID consult to weigh in was a big one. And I think that you can imagine why that would be. But sometimes, they're like, oh, they're covered for now on Vanco for that MSSA. I'll see them tomorrow. That's a whole day of vancomycin when they could be on cefazolin. So that was definitely something that we needed to think about ahead of time and try to tackle with our colleagues in ID to give like positive iteration as they were getting the consult to say like, oh, do what the pharmacist said, and I will see them tomorrow, for example. Okay. And then prescribing culture, that's a long-term change. That one's pretty hard. But things we can work on over time is having more presence, doing more education, and then obviously culture change is slow. So that was in our slow bucket. So this one I think is really useful. Got a little messed up. For the axis is effort, and then the y-axis is impact. And so you have all your solutions, put them on this grid. So what things are going to be low effort versus high effort, and what things are going to be low impact versus high impact. And so that's kind of how we determined the pharmacist was the way to go, the frontline pharmacist. We already had our pharmacists are so well trained. They are already doing this sometimes already. And it's once we gave them the tools, it was pretty easy to get the academic medical center to take this up pretty quickly. So that was high impact and low effort. So that was like, we should do that. But there was other things, there's Haiku and Epic. So that's like an automatic alert to your phone. So trying to get prescribers to see it faster. But then we would have had to make everybody use Haiku on their phone. So that was like, that's going to be a lot of effort. It's probably not, it's a potential solution. And maybe long-term, it could be useful for many other things. But adopting a new system that's a high effort and potentially mid to low impact. So putting your potential solutions on this can help you decide which ones to go forward. Okay, so real world, this is what we were addressing. So the primary teams were not being given the results quickly. So our workaround there was pharmacists notified in real time 24/7. So we were able to get them to use the in-basket, which some of them used for other things. So that was kind of a workaround. And there could be a faster way, but again, we would have had to get people to use Haiku, for example, and it probably just wasn't worth the time and effort to do that. Okay, And then expanding coverage is probably the biggest thing. So this is where we filled in the gap here, is we started covering 24/7 by training the trainer for optimal therapy. Control plan. This was a big one. So create a monitoring plan. How are you going to make sure that your result is sustained over time? And then what are you going to do if it's not? And then completing your project documentation and reporting results. So this was our timeline. We had to iterate and reiterate and reiterate and reiterate. So this took many education sessions. We did every month, we looked at what the results were, and we really looked at it once a week, real time, reviewed what the pharmacist recommended. So our documentation, they had to document every single one they looked at. So we had a timestamp for as soon as they looked at that, which was very quick. They were very quick to review the result and then track their intervention. So there was a few like one-offs that we caught. So, you know, Candida is not a contaminant in the bloodstream, for example. Like that was a one-on-one reach out versus like several people would get the, you know, staph epi with a MEC gene. They'd be like, oh, thanko, you know, let's like weigh a couple things. So that was more of a broad education for everybody to get. So reiteration. And then the control plan. So this one, oh, this was a little old. I took out your name, Mike P, but sorry, you're on there. So this is really important for sustaining change. And this is the C in DMAIC, the control plan. So your time from your BioFire result to your optimal therapy. So our goal was 4 hours, our limit was 8 hours. And so you kind of panicked and you had to intervene, you had to do something if it's creeping above 8 hours. So we're monitoring that over time. And if we have like 1 month where we're getting higher, then we're going to be really careful. And then we probably need to send out re-education. So then we have recommended action steps based on that. And so we were also looking at our risk-adjusted length of stay was kind of our biggest overall outcome. And so we also had a metric for that. If that one went above 1, we needed to look at the whole process again because we did decrease our risk-adjusted length of stay. Okay, so outcomes. We had really good results, which was awesome, and they've been sustained now. We implemented this 1.5 years ago, and so we did build a dashboard so that we're continuously able to look at this, and now we're gonna roll it out rolled it out system-wide. So the system-wide shift is also a consideration. So each of your sites is going to have a different problem probably. It depends on the hospital. Sometimes, you know, some of our hospitals have ID consult who are not NM employees. And so they're really hard to give education to because they're contracted. So different issues are going to be with different sites. So we have proven that our pilot has worked, but now how are we going to address rolling it out to the other sites, especially if they don't have a BioFire machine? That's a whole different set of delays. So that's sort of where we went next was now we're in the control for the pilot, worked out well at the 2 hospitals, and then how are we going to implement it at the other sites, going back through the checklist and figuring out what your gaps are this time. Okay, outcomes. Okay, so stewardship tracking outcomes. I had some prompted questions and they didn't show up. So what outcomes are you guys tracking? Can you just shout out like what you track usually? DOT. Yeah. Okay, by like the antibiogram? Yeah, antibiogram tracking. Anybody else? SAR. Yeah. C. diff rates over time. Yeah, awesome. Okay, so I have some potential ways to make your data a little stronger if possible, or to work towards that, which might appeal to your C-suite. So you've got good, which they don't really care about days of therapy. They're like, that's nice. And the antibiograms, like we really care about these things and we can show our intervention changes, but it's really hard to communicate that to stakeholders. So better, we've got percent appropriateness, so relating it to the exact initiative that you're doing or tying it in another way to the indication or the intervention that you're doing is better than overall DOT or SAR if you're able to, like, you know, only look at UTI patients if you did UTI. And then the best is, of course, attach it to the outcomes that people care about. So C. diff is a really big one. So can you show that you decrease your ceftriaxone and show, you know, a few months later, your C. diff goes down. Attach it to high-level outcomes like length of stay, readmission, or mortality. So those are also, you know, hard to attach, but the more you have over time is going to be useful. And so I'll show you an example. Do any of you have a dashboard that tracks any of these things? One person? Okay. So we had big dreams, and so this is an example of our dashboard. So we can filter it based on indication. So this was the example of our UTI initiative. So you can see here, that's where our percent appropriateness went up. So it was about 35%, and it went to about 65% appropriateness for UTI treatment. So as previously discussed, that was ceftriaxone, Cipro were not appropriate, and then appropriate was cefazolin and things like nitrofurantoin and Bactrim. So that's where that percent comes from. And then we can look at our risk-adjusted length of stay, which this comes from Vizient if you're a Vizient hospital. So that's where that comes from. But you can also look at median length of stay, which ours didn't change, which again, it's cystitis. Do you expect mortality change from your antibiotic use? Probably not. But you want to make sure you're not causing harm. And if it's a bigger outcome like bacteremia, perhaps you are decreasing your length of stay or your mortality. So those bigger measures are useful to track, and readmissions, of course. So depending on what your initiative is, those bigger outcomes to attach to your antibiotic use is really helpful. And if you can make a dashboard like this, it's worth requesting, because now we don't have to recreate the wheel every time that we implement a new initiative. We can just look at pre versus post. But this did take a long time to build. Okay, and we have several other pages to the dashboard. So you also, you know, equity, we've had a big talk about equity today. So building in from the front, shout out. Building in from the front, demographic information. So then you can look at, you know, your particular indication or your antibiotic from a filter, and then look at your distribution of, you know, you can put billing information in there like Medicaid versus commercial insurance. You can put in race, gender, age, everything like that. So I would recommend, again, if you're going to do it, just build it in from the front, and then you don't have to recreate the wheel every time. And then we had some more details. So IV to PO, we had proportions. So that's the pie chart on the right. The top 10 medications. So if you don't know what your problem is, that's also, you know, we filter it based on unit. And so it'll tell you like what your top indications are, and then what your top antibiotics are for that particular unit, things like that. So dream big from an outcome standpoint. This requesting this sort of thing and then taking the time to do it is going to save you a lot of time in the long run, so that we can pretty easily track these things. And this is system wide, so all of our little small hospitals also have all this data. So that was really useful for a health system. In the meantime, have you guys used Power BI? A couple of people. Okay, great. So if you have access to it, I guess the first thing is figure out if you have access to it. If you don't, this is an easy request. It's like not that expensive for your health system to like get you Power BI, but it's sort of a measure that you can, it's not that difficult to teach yourself. It's essentially a pivot table that continuously gets updated with your data, so you don't have to like keep making new pivot tables. So if you don't, you know, this was our Band-Aid with the UTI project, was to make it into a Power BI so that we could track our data and report it back. until we until we got our dashboard up and running. So Power BI is great. It's very user friendly. And instead of making a bunch of pivot table graphs every month, you can just continuously update your data in the background in the Excel. Okay. I feel like I had one or two more slides, but that's okay. It's fine. Okay. So takeaways, the highest quality stewardship data, try to consider if you could do it. We're really lacking on high quality stewardship. So if you can use implementation science or some of those checklists to make your data better and better to publish, try to use those because they're pretty helpful. And that Langford 2024 summary of the options of the checklist was really something you should take a look at. And then there's still value, obviously, in quality improvement projects when the resources are limited for something like implementation science. And then there are interventions you can take today, talking to your programs about what's possible, what things you have already. Do you have process improvement? Do you have finance data? People will say, tell me about cost savings. And if you don't have finance data, how are you supposed to do that? So getting your, top 10, top 20 antibiotic spend, things like that, are things you can do today to help you figure out what things will implement and also give you more resources over time if you save money. And of course, benefit your patient. All right, that was my last slide. Any questions? Thank you. Any questions? Anything cool you guys have done? Mike.
For these high-level projects and dashboards that you work on, could you kind of outline what you think the three biggest challenges are someone to get that done?
So the question was getting these big, large scheme things done. What are the biggest challenges? I would say definitely number one, if it's been tried before, try again, because persistence totally paid off. I submitted a ticket to build this pie in the sky dashboard, and then like a year later, they finally got to it, because every month I had an email and I just resent it. And I was like, hey, just wondering what the status is. And that's also, if you have a ticket in, that's something you can ask your management. If they're like, wow, you're doing this really important stuff, what can I do for you? Funny you should say that. I have a ticket with IT. Can we get it moved up in their priorities? So having like a couple tickets in your system at all times for like dream things like that. Once we thought about all these things ahead of time. So like, I saw the dashboard, I think it was like Charms or something. That dashboard was awesome. So like steal other people so that you're ready. Like if the time comes, what things you want built into it, what's possible. So yeah, I think that was one of the biggest barriers, was just like you put the ticket in and it takes so long, but someday they'll get to it and then you'll have nice things and you won't have to request data once a year for your initiative that happens in the past. So yeah, any other questions? Yeah.
What external stakeholders outside
outside the hospital system? Did we involve stakeholders?
health department?
We do incorporate NHSN data into, or it's like being built right now into our dashboard. So there's like, we had phase 1, which was like, we need length of stay, we need readmission. That's hard to get in chart review, so we prioritized phase 1, and phase 2 is happening right now, which is C. diff on the patients attached to the patient. There's a few other things like NHSN. Yeah, we do use NHSN data for sure, and we're working on incorporating it into the dashboard more. I don't think we had too much outside like NM, yeah, at the moment. but definitely wider like inter-system work is super important. So yeah, more data better. Any other questions, comments? Yeah. Yeah, yes. Okay, so one of the big things that we used to prioritize our projects was we had, okay, so like this, we have readmission, mortality, and length of stay. And so we looked at all of our indications and we're like, which ones have the highest bang for our buck? So we definitely have an issue with CAP. It compared to UTI, much longer length of stay and mortality and readmission. And so that, you know, like that's a pretty clear next step. And that's likely where we're headed is a big pneumonia initiative in the next year. So yeah, this dashboard is really helpful to figure out where your gaps are as well. Good question. Anybody else? All right. Thank you so much.